Well, a couple things that you might want to know. I'm a clinical psychologist by trade. My main emphasis, my whole career has been in behavioral medicine. And I've lectured in 48 of the 50 states. I was telling Rick, the state of Texas hired me for all of next week to help them on issues that we're going to be talking about here today. But about a week every 6 weeks, I'm out of Minnesota doing things in other states. So there's a lot of good stuff happening here that people think we know stuff. And that's good to hear. So that's one of the things. The other is I'm presently working on 4 PIP grants. Last year 2, this year 4. And of these 4, I think all 4 go into 2020 also. And as a compliment to your team representing you guys, your team has really been awesome. We've had, 3 or 4 meetings discussing things and trying to, always on these things, it's trying to make sure everybody agrees what it is we're doing and trying to get a common vocabulary and a common way of being. I've been very impressed with the organization and diligence from you guys, your team. So that's a good thing and it's a compliment. Some of you I saw last week down at Leading Age, and I was there on Tuesday all day, 7.5 hour lecturing, and then on Thursday. But a part of this that I think ties in that's important, particularly for administrators, DONs, and directors of social services in this room. When I was checking in on Thursday, Mary, I forget her last name with the health department. Huh? Yes, her. And I've known her for many years. Last year we did 5 cities in 5 days, but I've been on the speaking docket with her many times. She called me into a room and wanted to talk about what's going on in long-term care. So anybody that has been within a mile of me since that last Thursday, I've been talking about this. That what she was telling me is that in 2018, 9 IJs were offered. 9. Since the 1st of January until last Thursday, 9. Yeah. And it is stimulating conversations. And she took me into a room and wanted to talk about this, about what I thought was going on. And I said, I don't really have the answer because I'm not a surveyor or whatever. But there's a lot of concern that people are not paying enough attention as to who their customer is. That was one thing. The staff turnover is still very high. In some homes, it's less than others. And the sensational cases, I think, is going to be another thing. I'm sure all of you know of the case in Arizona of the woman in the nursing home, 29. Suddenly the staff found out that she was delivering a baby. Nobody knew she was pregnant. They did DNA and found the male who impregnated her. I'm involved in that case behind the scenes. And that's everything I told you is in the public domain, so I'm not spilling the beans on anything. But there are a number of cases like this around the country that is catching the attention. And those of you that work in assisted living have been watching the articles, and that there's regulations are coming. Regulations are coming. Paul Revere saying the regulations are coming. So the world is changing in that way. So it's just something as a heads up that there's a belief something is really in the air, and that there's going to be, I think, greater scrutiny. Yeah, Tammy. Yeah.
She was like, why are you reporting these small little bruises?
Yeah.
And the surveyor that was in our building said, you report those.
Yeah, I know.
It's so subjective. And we don't think, basically, she said she's not trusting our judgment.
I'm not going to tell you exactly what went on behind closed doors, but what you just said was mild. So I'm just saying I'm a humongous advocate for staff who work in assisted living and skilled nursing facilities and the residents in the buildings. But I think we're going to see some turbulent times in 2019 and 20. So, this talk today is about really helping leadership get on board. And I was talking to Rick earlier, and I asked him if it was okay if I shared this story because it's going to kind of make him look bad. But I've known Rick probably 25 years, and there's never been anything that I've ever known other than him doing a great job. But what caught my ears, it was just like when you said a few things, it caught my ears. Let me ask you a question, Rick. Who is the medical director of your facility? Mike Stockman, good buddy of mine, Mike Stockman. So when I got here, I asked Rick, I said, how's my provider from our group doing? And he couldn't tell me. And then you asked one of your staff, who kind of thought it was Emily. That, if nothing else, is that captures how mental health is treated in healthcare in general, not just in long-term care. But what's happened, if we look at this, so that wasn't so bad, Rick, but that's kind of a common thing, is that administrators clearly know who the medical director is, but many of them do not know who the behavioral health provider is in their building. But in the old days in behavioral or in healthcare, there were 3 silos. This is how everything operated, and very much in long-term care. I went in first time into a nursing home in December of 1980, and it was like, what are you doing here? How are you going to help? And if there were like, let's say 15 requests for the staff wanting me to see a patient, and they had to get a physician's order, maybe 1 or 2 would be authorized. And a physician would say, what? Well, who wouldn't be depressed that they're 80? Can you imagine how ageist that statement is? Think about racism and sexism and other isms. That's an ageism statement. What we now know, and there are some homes that I still go to 7 nursing homes a week, but one of them I'm thinking of in my head, I covered for probably 30 years by myself a half day. Now I have 3 other providers with me there. Still a 100-bed facility. Why? The staff are identifying people more readily, and the medical team. And B, what we know is that the patient population coming into facilities is more difficult. Even in a place like Masonic that for many years, like many others, could take the cream of the crop is staying at home with services. The next group's going to assisted living, and often the toughest of the tough are ending up in these buildings. And that trend is going to continue significantly. So in the old days, it would be like these are, quote, nursing homes, health care, but nobody ever looked at the chemical or the behavioral health. Then in late 80s, there were 2 studies done. One of them said 67% of people in a nursing home have a bona fide mental health disorder. 67%. That's from 1989. In 1990, another study was done asking similar, but the questions were a little different. This number jumped to 93%. In my experience, and I've been in thousands of nursing homes in my career in Minnesota, across and around the country, I don't believe it's 93%, but I don't think it's 63% either. It's probably an estimate around 70, 75. Everybody believes that it's gotten tougher now. Well, what's happened is that, like I know Masonic and you guys at Mount Olivet and whatever, your homes have a TCU. And TCU has heated up the system big time. And many of the facilities have the same ratio of social workers as they had. Take a 100-bed facility. Prior to TCU days, there would be 120 people going through there in a year, right? Death or moving. I talked to an administrator the other day, 100-bed facility. How many people went through here? 1,400. The social service staff is the same ratio as when it was 120. And if you look at behavioral health, social workers, in my humble opinion, are often used for sock sorting, looking for hearing aids, and not used as the first line of clinical intervention. So, to the administrators in the room, I strongly would recommend more social workers and more TR in your buildings. People never complain about how dull your needles are in the building, but they do complain about the most powerful medication in your building. And the most powerful medication in your building is your staff. And anytime you interact with somebody, you have an opportunity to cause a positive side effect, a neutral side effect, or a negative side effect. Right? Is that true? And with pills we give residents, if it's a negative side effect, we stop it right away and do something different. But we have a lot of staff working in our buildings that cause a negative side effect. So as leaders, what you want to do is help people at worst cause a neutral side effect and at best a positive side effect. We now know, for instance, in TCUs, if you admit somebody under 65, there's about a 70% chance there's an active substance abuse problem. The other day, I saw 6 intakes on a TCU in the morning. All 6 were under 65. 4 of the 6 had an active substance abuse problem. One of those I was seeing because she took an overdose of narcotics. She was prescribed narcotics, and then her husband brought some in. And what was interesting, that the staff were surprised, she was 52 years old and broke her ankle and ended up in a TCU. How many 52-year-olds go to a TCU with a broken ankle? About as many as is in this paper. And I said, does this bother anybody? I mean, what more is the story? Well, we don't know. Well, then we find out about ODing on oxycodone. Then we found out that there were more hidden in her room. She was sent to the hospital, and then they found that she was hoarding them in her bed in the hospital that her husband brought in. So there are certain things that are happening. The younger people coming into TCUs, and many of them bringing drugs, sex, and rock and roll. And it's important to know that if you don't figure out how to manage these situations, you end up being managed by the situations. So the old days, there were 3 silos. In fact, to treat somebody with a chemical health problem, you had to be a recovering addict. That, you know, I'm a licensed drug and alcohol person. I couldn't be hired by any substance abuse program because I'm not an addict. Those days are long gone, thank God. But that's how it was. So this was a silo, and if you came in there with an antidepressant, you had to get off it. These days, that would be considered malpractice on that facility. And I consult for 3 of these programs now. So what's happened is this integrated model right here where nothing is pure medical, nothing is pure behavioral, nothing is pure chemical health. So if you're thinking about the rules of participation that came down in November of 17, the federal law said, dear facility, you had better improve the behavioral health of your residents. And you better figure out how to do that immediately. And you better improve the behavioral competence of your staff. Those 2 things were just pounding away. Now, what many people are concerned around the country is many facilities have not moved off the dime on improving the behavioral competence of their staff or the behavioral health of their residents. The grant that you guys have is looking at how to improve symptoms of depression and how to get people's experience on the QOL, saying that they've had a better experience. And I think that how that's moving ahead can be a great way to, what your staff, Amy and the rest of them have been doing, putting together, there'll be some tools. I'm a profound believer that you cannot train your way out of this. These guys have heard me harping on this significantly. Many people say, let's get some videos. Well, you make videos for us, and I made zillions of videos in my career. But videos are just videos. It's like this video today. If there's no teeth in it, it's just a video. It's like watching a movie on TV. So one of the things I think that is profoundly important for all the administrators and leaders in this room of recognizing, forget your grant, under the rules of participation, think about what you're doing differently in the past year to improve the behavioral health of your residents, and what are you doing to improve and document that you're making improvement for your staff. Both things are very, very important. And that's why, Rick, when I said of not knowing who your behavioral health provider is, that person, like very quickly, whenever I walk into a facility, I don't go to a folder and go, who are the referrals? That is not improving the behavioral competency of your staff. That's old school. What I do, I walk into a building this morning where when I got to the facility, there were 15 people in the room. Clinical nurse managers, director of social service, the social workers, director of TR, and ADON and DON. And we went over all the new referrals. We reviewed all the active people on our caseload. And then we all sign off on it. And then there were certain themes that we talked about. And in those themes, we write down. So when DHS comes and says, dear facility, what are you doing to improve the behavioral health of your residents? We have 52 pages, generating one a week, as to what we're doing to improve in talking about people, keeping them right on the forefront. So you, Rick, as an administrator, if you go, who's being seen by our behavioral health provider, you get that form and you know exactly who they are. There's no on it, no mystery. And we're documenting, talking about residents, and today I was differentiating between obsessive compulsive disorder and obsessive compulsive personality disorder, and probably spent 10 minutes on that topic, but that was put down as one of the themes discussed to improve the behavioral competence of the staff. Again, 52 of those type documentation trail. That's one of the ways to get better at what you're doing. One of the things that in the past 2 weeks, seems like every morning I wake up and my driveway was plowed again. And I'm thinking, my God, there goes another $70, to the guy plowing. And he's gotten a lot of $70, or will when he sends the bill. There's been a lot of snow. Well, I pretty much know every year that I'm going to have to pay for snow plowing. So I know Rick's an administrator. Is there any other administrator here? I know Tammy, yeah? You are? Okay. Do you have a budget for snow removal? Do you have a budget for lawn care? Yes or no? Yeah, okay. Do you have a budget for one-to-one supervision? No. When I've asked that question all across the country, Arizona, they don't have the snow plowing one. But nobody has a budget for one-to-one. In my opinion, to the administrators in this room that are creating budgets, it is in your best interest to create a budget. It shows, again, that you understand you're admitting people that at times need a one-to-one. Because when you don't have it, it's like everybody's undies getting a knot that we're spending all this money. I don't believe that you can run a skilled nursing facility in today's world and not at least once during the year do one-to-one. You just can't. And if you're not having a budget item, it says to me, and it would say if a bad event occurs, that you were not understanding the game that you're in. The acuity is so high. And the other thing, as a pointer to all of you in the room, I've been involved in a ton of cases that are on a one-to-one to the facility, and I leave, and maybe 5 days later over the weekend, somebody gets the bright idea of sending them to the hospital. Because many people believe magic occurs there. And they get started on medication. Now you got that problem. Now we as taxpayers pay $30,000 to $35,000 for that hospitalization. And this is the important thing to know. 70% of that group have their medications adjusted downward within 30 days of returning to the facility. And people have asked me, Dr. Brose, how do you stop that? I said, I'll tell you exactly how you do it. You make the administrator pay for that hospital stay, the facility. And he or she's going to say, dear staff, can't we treat them here in the building? That would happen instantaneously. And in my world, I haven't hospitalized somebody in probably almost 15 years from a nursing home. And believe me, I'm in the difficult behavior business. Because I know what's going to happen there, medication. We can do medication in the facility. And there's no way to have a dementia unit, for instance, and not have peer-to-peer aggression. Would you agree with that, those of you that know anything about it? So when you say you're admitting people with dementia, you're saying we're admitting people with a full tank of gas, a large gas pedal, and no brake. That's what you're admitting to your building. Think about us driving around in these past 2 weeks with no brake. One of the things I discovered, my four-wheel drive vehicle is great at going, but it stops horribly, you know. It maybe puts me in harm's way because I can get going faster. But my stopping is equally poor. So the game we're in is admitting people with a diagnosis of dementia. You're basically admitting people into not a memory care unit, an impulse control disorder unit. I can tell you we have never gotten a phone call at the clinic. You got to come and see this patient. They have a memory problem on our locked unit. Never happened. Never will. But the number of times of peer-to-peer aggression, sexual acting out, throwing the remote control, throwing the tray, all these impulse control disorder. Memory is one piece of dementia, a very small piece. Dementia affects planning, impulse control, abstract reasoning, judgment, insight, etc., etc. So another learning piece here for the leaders is to I don't recommend you here at Masonic in this nice neighborhood say we now have an impulse control disorder unit. The neighbors might get mad. But you need to educate your staff on day one, actually before day one, in the interview, that they're signing up to work on a quote-unquote impulse control disorder unit. Would you agree with that? Because staff lie to themselves. They say my license is on the line. I encourage you to go to the Board of Nursing. I've done it. How many nurses have lost their license because peer-to-peer aggression? I'll save you the trip. It's 0. Where people get in trouble is they don't operate as a team, they don't put a plan together, they don't follow the plan, and most importantly, they don't document what they did or didn't do. That's what people get in trouble for, not peer-to-peer aggression. Nobody that works in geriatrics for a second believes there's not going to be peer-to-peer aggression. It ain't going to happen. Or do you think anybody in the school believes that they can cure bullying on the playground? It ain't going to happen. Can you reduce it? Yes. Only put one kid on the playground and guess what you've just done? Reduce bullying. Or you put them at the opposite ends and you have 4 of them. But you have to think smart about how to do these things. As I've said to your team on this PIP grant, I do not believe that you can train your way out of this problem. I'm 100% confident of that. And there's a fair amount of research that will say this. With the staff turnover, you train them, what's your turnover in your building per year? So 25% of your training went out. And that's a pretty good number, right? 25, yeah. I mean, their home's 60 and above. California, it's much higher. But, so your training goes out the door if you say this is just about training. So here's how I would like to encourage you to think about it. I've never gotten to a point where I'm not amazed at all the medication that's given to residents in a nursing home. Those med carts must have 2 million pills in there. Now, how do they keep all that straight? Anybody know? Well, number one, you hire people that had it pounded into their head for either an LPN or RN school. You better make sure you're handling these medications like it's nuclear waste. Otherwise, it's a med air and you're in big trouble. Is that true for the nurses in the room? Yeah, so you hire people that get it. You don't have to convince them whether they were born in Cuba, they were born in the east side of St. Paul, whatever, they get it. All right, so you've got that. But the other thing that facilities have done is they've created protocols around medication passing. And this is where leadership comes in. Somebody, and I would argue it's probably the administrator and DON, went out and bought something called a med cart with a number of drawers that locks. And they also said, our protocol has to include wheels. And now our protocol is it's got to be big enough on the top to put a laptop. We didn't have those in the early days. Be a, the old Mars, but. So then a nurse or TMA can go in there, take this handful of meds, give them to you in room 101, grab this handful, give them to you in room 102. For you, I got to go to the real strong stuff down here. Give that to you there. But they keep it straight, right? And then they know that these things need to be passed, many of them, 4 times a day. And I've often joked, a snowstorm could hit, a hurricane, an earthquake, and let's throw in a tornado in a nursing home. Hits the nursing home, and by God, those medications are going to get passed. But when it comes to behavior programs or customer service, it's a whole different ballgame. We're working short. So in order to improve outcomes and improve your customer experience, you want to make sure that you're looking, oh, thank you so much. You must have been reading my mind. Oh, God, I love when people read my mind. Don't do it right now, though. Thank you. But that if we can step back and say, what is our mental health med cart? What kind of wheels are we going to put on this thing? It will help you. I do not believe the task before you is tremendously costly or tremendously complicated. I really don't. But the leaders need to understand that we need to catch our staff doing things right. We work in an industry where everything is negative. On the news, nobody says, hey, my God, we're in a snowstorm. Look at all the staff that came and took care of our older adults. Right? But everybody's bitching about this government shutdown, right? You've heard about this shutdown? And they aren't getting paid. I'm screaming at the TV going, but they are going to get paid over here. All those people are getting paid. They didn't get paid timely, but they're getting paid. Many of our staff have to get here because of the ratios that need to be to care for vulnerable adults. And thank God, no matter where a person was born, we have a lot of people, not enough, but we have a lot of people that say, I'm signing up to do that. That's fantastic. So as leaders, let's make sure we're doing everything we can to catch people doing right. Let's make sure we are not allowing, as administrators and DONs and directors of social service, we are not allowing demotivating statements. What are they? My license is on the line. Have you ever heard that one? You ever gone to your dentist and he or she says, you know, my license is on the line? No, but you're in a nursing home. It's like everybody drank the same Kool-Aid. Every 10 minutes, they'll evaporate if they don't say my license is on the line. And then the other one is the health department says. I cannot believe the misinformation of people telling me what the health department. I'm with those guys all the time. Here's one. Get this one. And I wrote a paper on this about 10 years ago on fecal smearing. And I have almost 100% hit rate if you have a fecal smearer, putting them in a jumpsuit with the zipper in the back, you know? And I say that to a team. Guess what happens as soon as I say it? It's a restraint. I'm going, oh, tell me something I don't know. So is Prozac. So is Seroquel, so is Depakote, so is Ativan. How come people's undies aren't getting a nod about those restraints? And those are going into the internal environment of the patient that could kill them, right? Or other adverse side effects that doesn't kill them, but adverse. Putting a jumpsuit on where a person cannot get to the feces to smear. Okay, it's a restraint. I personally don't agree with it, but I know the health department sees it as a restraint. But this is how you get around it. You have them in it for 3 hours, and then you take it off. You release the restraint, then you put it back on. Here's another demotivating statement. If you hear it in your buildings, please eradicate it. We've tried everything. Unless you've had the world's leading experts in your building, there's a very good chance you have not tried everything. When people believe they've tried everything, it demotivates them. It demotivates them. So I always like to say, let's lock that door, let's get in here, and no idea is a bad idea. Ideas are just ideas. We aren't implementing ideas unless we all agree on it. What can we do creatively to work on this very complex problem? And often some of my best ideas come from a CNA, come up in the team, of people really chewing on it and not believing that the hospital is going to fix the problem or that special nursing home right on the Minnesota-Iowa border, right down by 35, because we can't meet their needs here, we need to send them somewhere else. They have a booming business down there at that joint. Now, you aren't going to go looking for it, are you? Good. And here's another one, try to avoid in your building. They have behaviors. Ever heard that one? I just want to point out that nodding is a behavior. Blinking is a behavior. When you hear a staff member say they have a behavior, what the staff member is really telling you, that person is doing or not doing something they believe they should or shouldn't be doing. It's another demotivating statement. I often will tell a story. I hadn't gone to a bank in years, and then I went in about a year ago, and this woman says, "Oh, can I see your ID?" So I, pull out, give her a driver's license. She goes, "Oh, John, how are you today?" I go, "Pretty good, pretty good." "What are you doing?" "Well, I'm working." "Oh, what are you doing tonight?" And I said, "Well, I play in a rock band. I got to learn a couple songs." "Well, what are you doing this weekend?" "Well, maybe playing with my band in this gig." Now my heart's going like this. I'm thinking she's hitting on me. But then I hear her cohorts on each side of me, those little partitions that are this big so you don't hear anything. The same conversation went on. You ever had this experience? Look, everybody nod. because the administrators, the thought leaders of that bank, hold a gun to those people because they are the first line of being the banker. That if somebody's in the bank and they have a good customer service, they're more likely to get a car loan at that bank, a mortgage, and on and on. I believe in long-term care because many of our customers can't vote with their feet. We've gotten lax in the customer service arena. If we look at mental health, the DSM-5 is this thick with mental health disorders, that thick. So if you think you're going to train your people on schizotypal personality disorders and differential diagnosis of schizoaffective schizophrenia, you're wasting your time. It would be inappropriate. But what you have done, like with AIDS, let's say, in your building, don't you, if they see something like redness on the buttocks, do they have to know the etiology of wounds and how wounds can cause sepsis and sepsis can cause encephalopathy? Do they have to know all that? Or do they have to know if you see redness, tell a nurse? Is that right? Very basic. It's the same thing on mental health. If you're seeing somebody starting to get ramped up, and they're at this level right now, they were here, they're here, if something doesn't change, what's the probability of them getting here? It increases. So this again is trying to help staff. You don't have to know everything about PTSD. Or we were talking about trauma, which is one that clinicians, not the health department or CMS, but a lot of clinicians are very worried about that one coming down the path, the trauma-informed care. Why am I riled up about that one? The literature is quite clear. One of the most traumatic things that occurs to a person in their lifetime is being admitted to a nursing home. So if you have a 100-bed nursing home, you have 100 people that were traumatized by being placed. I just had to place my mother in the nursing home at age 90 this past October, and I'll tell you, it was very traumatizing for me, and I'm in the business. You know, feeling powerless, and I'm mad at God for doing this to her, you know, and on and on. So I think it's, oh, the other thing I wanted to say about the training, I said, you know, you have 25% turnover, but the literature says training in a nursing home has a life expectancy of about 30 days. So if you don't have a mental health med cart with wheels with the computer on the top, a protocol, it will fall right by the wayside. In my opinion, under this grant, but forget the grant. It is what I've spent the past 39 years of my life of getting rid of psychotropic medications that are needless, getting rid of side rails and mechanical restraints. I've been involved in that going right back to the early 80s. We have made profound improvement in that area. The next step that CMS was trying to do is push nursing homes to understand you are not a nursing home. You are a holistic home. And you need protocols around spiritual care, psychosocial care, mental health care, and medical. You've got to have it in place, otherwise it'll fall flat. There's a phrase that goes something like this: if you don't know where you're going, any road will work. If you understand, if you're admitting dementia patients, you're going to have sexual acting out, you're going to have rummaging, you're going to have pacing, you're going to have peer-to-peer aggression, you're going to have resistance to cares, you'd better be on the road that says these are all impulse control driven. We better be on impulse control highway and try to find ways to manage these things. You're not going to fix most of them, but how do we manage them more effectively? The other thing that I think is very important in facilities, I don't have enough time to rev up, but to really make sure as leaders that you're helping your staff to not personalize things. You know, kids call other kids names, don't they? Do people in the neighborhood you live in call someone else a name at least when you're having a beer on your deck on the weekend? So, residents, many of them, are very angry. They're hostile dependents. 99% of Americans say, whatever you do, do not place me in a nursing home. But what happens, they end up there, they ain't happy campers. That was one of the things that was interesting when my mom and my dad were touring this place. Look beautiful. But the admissions person was too perky. It was like she was selling condos in Florida. There was nothing in that day where we left the hospital, drove 1 mile to the rehab unit, the TCU, which then had the long-term care beds in the other wing. There was nothing happy about it. But it was like we were here emotional. It'd be like a funeral director. Hey, you having a good day today? Probably not judging it. Now, that's better than her going, I am glad you came to our home. That's too much the other direction. But modulating that is a good thing. But people get called names based on what they see. Do you think I've ever been called the frickin' fat ass? And I haven't been on Jenny Craig either. Why do you think I haven't been? I'm not overweight. Well, I'm 10 pounds overweight, based on my own definition. You think I've ever been called Baldy? I haven't. You think I've ever been called crazier than a shrink or crazier than a loon? Or there's the crazy doctor? Yep. I always ask my geriatrician friends, have you ever been called the crazy doctor? Never! And they're crazier than I am. But I have been called, you're Dr. Brose? You look like a gold darn rooster. My hair being spiked up. So people are going to call people names. We have to hire staff that have a built-in anti-personalization suit. We need to get creative. How did this person get so good to get nursing so ticked off with social service? How did that happen? How did they get so good at getting the day shift mad at the PM shift? They're masters at it. And we want to have a ton of curiosity in us, a ton of creativity, and a ton of, how are we going to manage this? Because we never see a nurse come out of a patient's room and say, damn it, he still has diabetes. But we do see him come out of a room going, he's still calling me names. He's still resistant to toileting. Now, this is another thing to keep in mind. On your memory care units, is there a certain percentage of people that are resistant to toiling, bathing, dressing? Would this be a true statement? Most people bathe, shower alone, and when you don't, it's somebody you know. I know there's that 1 in, I was going to say a million, 1 in 10 person that goes, finally, when somebody showed up. That's a joke again. Yeah. And most people, when they go to the toilet, they go alone. Well, now you get in the Happy Hills facility and you have a doctor's order of an assistive too. And people tend to not like that. Again, there's 1 in 10 that goes, hey, baby, you want to, you know. But most don't like it. And then some, and this is an important thing to keep in mind. What percentage of the people in your building are sexual abuse survivors? Statistically speaking, depending on how you ask the question, probably between 24 and 32%. So let's just say, to keep the math simple, 1 in 3. So might you have somebody who's highly resistant at those times, striking out to protect unresolved childhood pain with an adult strength? If we can get our staff to believe that, they won't personalize it. They still want to keep themselves safe. We don't want our staff to get hit, scratched, or whatever. And it's like Unfortunately, we don't have many Holocaust survivors still living. But if we go back to when I first started doing this in some of our homes, you'd have them, the empathy of staff towards them, because being in a nursing home mimicked what? Being in a concentration camp. It mimics. And we know, if you look at the organizational literature of congregate living environments, the incidence of abuse are sky high. Sky high. That when people get in high positions of power, it's likely to have an impact down here negatively. And we have that in our buildings. So we always have to manage the power differential. But if we can help our staff to really understand that you can't work in this industry and not be called names or have people be aggressive. It's just not doable. So one of the things I think that is important is adopt a philosophy. How are we going to manage this problem, just like we manage complex medical problems? If I were an administrator in a building, and those of you that are administrators, I'll give you this tip. It won't cost you a dime. But if I were you, I would take 1 day a week and make your office the hallway, where you're sitting in the hallway with a laptop with a bedside table. You can get some of, quote unquote, your non-important work done, meaning like budgets and all that stuff. But the important work of watching your workforce, remember I said your workforce is the most powerful medication in your building. You want to make sure that you're watching how they're interacting with your customers. In other words, the people that put money in your building and say, dear administrator, hire staff and put in protocol to make our experience here as good as possible. Sitting in an office, you'll never see this stuff. You'll hear about it. They aren't responding to my call light. But if you're making your office and like 1 day a week, the morning here, the afternoon there, or this morning here, next 2 mornings later over there, it will help you to get a better understanding of what's going on. This is not unlike parents that put in baby cams, we know in facilities, granny cams, or people with their dogs when they're away. You see what's going on, and it helps you to adapt or adjust things. I already said the importance of a budget for one-to-one. Another budget item, Rick, do you have in your facility, I'm going to put you on the spot again, do you have any budget for positive reinforcers? It says the budget item is positive reinforcers. Yeah. If you don't, I would strongly recommend that you have that, because you have them for your workforce, I'm pretty certain. And it's called performance review and a raise, or good performance, a bonus, or going above and beyond, a gift card to Starbucks or something, right? Well, a lot of homes have things like that. Those are positive reinforcers for the staff. But if you can get some money, and it doesn't take a lot, like a lot of homes have appropriated $200 a month for positive reinforcers. And it allows the staff to think, not just every time this resident misbehaves that we're going to put them on a behavior contract. We're going to start catching them doing things right. If you don't do something, we will give you love Diet Coke, we will give you 4 ounces of Diet Coke. If you don't do it, whatever. That we look at how to manipulate the environment with reinforcers to improve behavior. Now, sometimes when I suggest that, there'll be a staff member who says, well, Dr. Brose, isn't that like treating people like kids? The answer is no. Everybody in this room, I might be the exception, is on a behavior program called a salary. And I guarantee you, if all of a sudden your boss says, I'm cutting your pay by 50%, most people would leave. Why? Because the reinforcer does not match the task that you're doing. So for me, if you say, hey, John, if you stop doing that, we'll give you a chocolate chip cookie. You think that would work for me? It won't. I don't eat sweets. But if you said sunflower seeds in the shell, Now we're talking about something, particularly if I can't get them. So I've run programs where we couldn't get somebody to bathe, and the staff going, well, you stink and whatever, and man, they stunk to high heaven. But I would change the narrative to say, we need to get you treatment for your arthritis, and we have a hot tub, a spa down in the PT, and we want to get you in there for treatment for your arthritis. And by the way, what's something you really like that you don't get? And this one guy said, instantaneously, whiskey and chocolate chip cookies. So the plan was, don't talk to him about bathing, talk to him about his pain, his arthritis. We're going to help you with that. And as soon as his, I was going to say small butt, but big butt hit the water, offer a shot of whiskey and 2 chocolate chip cookies. There has to be a budget for that kind of stuff to make that happen. There's a lot of ways to influence people. So, some other things that I think are really important for leaders. I've been involved in so many projects in my career, and the ones that have far and away gone the best is when the administrator, the regional, the ownership is 100% on board. So that's why I picked on Rick earlier on, that if you leave this meeting today and say, you know what, I need to make sure my behavioral health provider is seen at the same sort of importance as the medical director, because it's the right thing to do. Because we have a person that's all-encompassing. So it helps you to lead with a vision. And then if you can begin to say the main mental health strategy, is being kind. In some homes, I will help them create the SMILE program. Like, I could be in China, I don't know a word of Chinese, and if somebody's speaking in Chinese and smiles at me and goes like this, did you see what you did? You smiled back. It's a universal language. But have we all seen somebody in our building walking down the hall like this? You have any of those in your building? Wells Fargo doesn't tolerate that. But why do we tolerate it? So my challenge to you, because particularly the administrators in the room, you are not by definition a clinician, but I'm 100% certain if you saw a staff member doing pericare without gloves on, it would catch your attention and you'd be on it right away. Is that true, Rick? Is that true? You wouldn't go, oh, well. You'd be on it. If you see somebody walking down the hall like this, do they have their customer service gloves on? No, they don't. So the more that you can say, and by the way, we know the best way for physicians to reduce lawsuits, improve bedside manner. We know in trauma-informed care, the best thing to do, be kind, be nice, be respectful. Get intrigued about people's story. Training will not get you out of this. But if you hold people accountable, starting right in the interview, that we see you as a powerful medication. Show me how you connect with people. Show me. What does it mean to you if I make this statement? How do we touch people in an emotionally meaningful way? Remember the old statement, people almost never remember what you said, but they remember how they felt when you said it. Last night I was on the phone with my mother's nurse last night, and I've met her before. She's an immigrant from the Philippines. This woman is phenomenal. I mean, if I needed a nursing care, boy, I'd want to clone her. She's phenomenal. But her style, and she'd go, Dr. Brose, I love your mother. I'm going to do this. I'm going to do that. Let me check on it. Can I call you back in 15 minutes? I mean, I'm sitting here. She's in Florida. She knows I'm concerned. And she did, you know. So the more that we can, with our staff, help them to improve their customer service skills, the better. You're not going to teach them how to handle somebody who has a long history of childhood sexual abuse and how to work with that when they're 85 years old with a little bit of dementia. That would be unethical. It would be inappropriate. But what you can do, independent of whatever the story is of any of your customers in 101, 102, etc., being kind, being nice, and helping them believe that they're the most important in the world at that moment to you. It's tremendously important. I believe one of your things is to improve your scores on that QOL, is if people really believe that you're really serious about how do you like the food here? What can we do better? By the way, do you have a special recipe for meatloaf? Yeah. Can we go tell the dietitian and see, and then you that? Or let's make 3 meatloafs, because you think my meatloaf here at the building tastes like crap. Let's get 3 of them here and do a meatloaf taste-off, or whatever. I mean, there's a lot of ways to do things rather than, you have no right to talk to me like that, which is what happens often. Customer service, customer service, customer service. Help yourself and your staff remember like Rick, your home, Chaska, who owns that? Who? So on the staff member's check, who signs it? Your CEO. And does it say on there whatever you just told me, foundation? You're not sure. But wouldn't it be cool if on every staff member's check, it had every resident that they cared for in those 2 weeks? And then what would really be cool, we could ask those residents, how did he do? And if we get an overwhelming majority did great, there's a 5% bonus. But if the residents say, awful, the worst ever, there's a 5% reduction, and coaching and giving something extra to the person who gets the extra. In other words, there's a disconnect between who's paying their salary. Most people, if they're shoveling your walk and tonight when you get home, if you hired somebody to do it and they didn't do it, you might be a little ticked off, particularly if you're on a prepayment plan. Or they shoveled it, but they left that much snow on the sidewalk, so it's very slippery, and on and on. We need to make sure, particularly the leaders in the building, that we're connecting to the staff. These are our customers. They're paying us. Not that corporation, not Masonic Home, not Crestview, not Mount Olivet. These guys are paying us. And what they did is they gave the money to the administrator and say, hire caring, compassionate, empathetic staff who understand we're sick, we're old, we have a lifetime history. Sometimes we're going to say stuff. But please get staff that can help us in these last days, minutes, months of our life that will tune into us. In other words, giving the locus of control back to the customer. That's what most businesses do, right? If you're buying a car, that's what they do. And it's person-centered. What kind of car do you need? What would you like? Do you have any kids? Well, this one has a lot of room for those child care seats or whatever you call those things. So in summary, before we end here, if you can think about what I, as a leader under this grant, because I think if these goals aren't met, there's a payback, right? And personally, I'm not really, I mean, if I owned one of your buildings, I would be concerned about it. What I'm really concerned about is making the life better for people who are in your buildings, and life better for the staff who choose to work with them. And the people in this room or the people on this tape can make a huge, profound difference by implementing protocol. And this is what we've been talking about in our meetings. You'll probably see more of them coming. And I'm being redundant here, but you create a mental health med cart with wheels, room on the top for the laptop, so that you can go, this is what we're doing to make a difference. I'm going to sit in the hall 2 half days a week. Or you might think it's such a great idea, you're going to do 4. Or you might think it's the most stupid thing and do at least a half a day a week. But do something different to make a difference. And by the way, one of the things when my mom's in the Happy Hills or Unhappy Hills nursing home in Florida, we were there for Thanksgiving and Christmas. And I'm never in a nursing home. Maybe you guys are doing this on Christmas and Thanksgiving. But they offered us a private dining room with linen, what do you call those things? Thank you, tablecloth. But what was really cool, every 15 minutes, they had somebody assigned, hey, Brose family, is there anything you need? Every 15 minutes. It was really cool. But what also was cool, when we walked in, there were two people on the side of these sliding doors. One of them was the director of nursing at Thanksgiving. The other was director of social service. And at Christmas, it was the administrator and director of social service. And I said, do you do this? Oh, every holiday. I said, that's really cool. He said, this is the way to meet the families. You know, it's one of the lines I've used for many years, is that when a patient's admitted to your facility, so is their family. And one of the ways to head off family complaints is get to know them, touch them also in a meaningful way. And they go, wow, they were here on Christmas? And then I found out that they did 2 shifts, you know, like one worked from 8 to noon, and then other leaders came in from noon to 5. Those are kind of things, you know, to think about. We've got a few more minutes. Is there anything you would like to talk about or questions on? Or yes?
So do you have some strategies for this impulse control unit?
I do. Well, a lot of them. A lot of them.
Because obviously impulse control is a big problem related to falls too. And it's not just because of mental health issues.
Well, let me ask, just in the crux of time, I know the question you're asking. If I came to your facility and say this is the dining room, and you four together use four, I'd say, why is this guy sitting here? And I can tell you when I ask that question, 90% of the time the staff can't tell me why. But there should be a reason, right? Why is this person's room there and not down there? Often can't tell me. Or they'll say, that's what was available. Where's your TR staff? You know, TR staff in terms of payment is relatively low. On a dementia unit, you don't need more RNs or LPNs. But you need eyes and ears and things to do. Think of this, when I train people on these units, or the leaders, I say, you've got to get your staff to think like the fire marshal. Okay, where are all the oily rags? Let's get them out of the way now before there's a fire. Because once there's a fire, the options are very limited. And most of the time in our facilities, the staff have a fire extinguisher on their back, and they're running around putting out fires all day long. So getting the staff to think like the fire marshal, how to get ahead of the problem. I have a program called the WHO program, or the OWL program. There are a number of things that can be done on these units to decrease the probability. Now, in the extreme, admit only one person to your unit, and now you don't have an arguing problem, peer-to-peer aggression problem. They aren't getting in bed with anybody, but now you have a bigger problem. You can't pay the bills. But whenever you get 2 or more people gathered, you're going to have problems. And that's true with kids, that's true in the neighborhood, hell, look at this one. Most people end up getting married, right? They find somebody that goes, oh, yeah, I guess I like you enough to move in and get married. But then 51% of the time they fire them. Why? Human beings don't get along very well. They really don't. And then we think it's a great idea to put 2 of them in the room together and expect them to get along. It's better to expect a homicide. Anybody other than me have thermostat wars at home? You do? You know how I'm winning in it now because we got a new furnace and I got the app. So anytime my wife changes the thermostat, I get an alert. So she thinks it's here and I can change it back. And the other day, that was about 6 months ago, and she's starting to catch on of what I'm doing. She thought it was malfunctioning and that we had to get a service repair guy out there. But anyway, when you put people in tight spots, or my mother, for instance, going out to dinner with her over the years, I often wanted to go like this, because if they didn't butter the bread all the way out to the end, she'd send it back. she would say, I want crisp bacon. I'll bet 99% of the time she sent the bacon back. It was constant. Guess what she's labeled in the nursing home? A picky, fussy, finicky, complaining eater. I said, she's been this way. My dad said ever since he started dating her, I said, this is the only thing I know. And I said, I guarantee you she's going to go to heaven and do the same damn thing. So there are a lot of things that can be done, but part of it is helping people understand to have fun working with these challenging situations. Nobody wakes up one day and say, you know what? When I get dementia, I want to be a royal pain in the ass. Or nobody ever says, you know what? I want to be a drug addict. Or I want to get addicted to gambling. Or I want to be bipolar. Or I want to have a borderline personality disorder. It doesn't go down that way. All of us have scars, don't we, from living life? Of disappointments or things where we believe we've been screwed over. And many of us have vulnerability to certain medical problems. Like if both parents have diabetes, you're at higher risk of having diabetes. If you grow up in a substance abuse home, a higher risk. Or a home that shows a lot of anger, you're likely to pick up on those traits. So if we can step back and say, and use my definition, most people believe cultural diversity is, race, religion, sexual orientation. Those are big categories. My definition is whenever two or more people are gathered, you have cultural diversity. And it is my responsibility, if I'm a caregiver of all of you, to understand your culture and not make a cognitive error that because you're a male and I'm a male, we have a lot in common. I may have a lot more in common with you, a female, than I do with you. But if you say everybody is different, and our job is to understand that differentness, appreciate it, and maybe even celebrate it, it'll help us do a lot better. Even somebody that's nasty, or, well, use my mom. She wasn't necessarily nasty, but she was a force to be dealt with, I guarantee you. But I learned a lot of good techniques from her in negotiating, and I learned a lot of things about, that's a part of her I don't want to be. Sometimes you go, I've lived it, I've seen the movie, and no, I'm not going to be that. I'm going to be over here. And a lot of us are that way. And if we can appreciate that and accept it, but it's got to, and I know we have to end, but you know the phrase, a chain is only as strong as its weakest link? I know leaders and owners often talk about we're an interdisciplinary team and we're committed to quality. You hear all this stuff. But then you watch the chain going down to the trenches. And we watch our staff not having on their customer service gloves. It will not get better unless we say having a customer service error is as serious as narcotics missing. And once you get to that point, you have your vision. Another thing I often will say is, if you're going to go for vacation to Winnipeg, that's different than if you say you're going to go to Miami. You got to know where you're going. You got to know what your vision is. Forget the health department. Forget them. Ask yourself as leaders, what would I want if I was admitted here? What would I want if I admitted my parents here? How would I want us to behave? Like, would we want to ask people, are you an early morning riser or late? Would you like to be on the east side of the building to get the sunrise or the sunset? What do you like to eat? Just things to get intrigued about how they're different and what might turn them on. So, I know we're running out of time. I hope this was helpful. And I want to reiterate, you've got a great team working on this PIP grant. And fortunately for me, I've been invited to be part of it with them, and I'm really honored on that. And There's some other models and protocols that I've talked, that I don't have time today to go on into them today, that will that help you to mimic like what you're doing with wound care, with some of these things around depression and challenging behaviors and on. But that will be coming down the line. So thank you for coming today. I know it was a little slippery out there, and but the roads are getting better. Yeah. Thank you very much.